If anyone has any questions that they would actually like to ask directly via the Zoom video chat, then we will allow a little time for that. And then once that's done, then I'm going to switch over and I'll moderate the remaining questions that folks have via the chat. All right? So Dr. Langdale, we'll let you get started.
Well, again, good morning, everyone. I've been waiting for this grand rounds for quite a time. We had scheduled Dr. Lebares to be a visiting professor with us in March, and we had to delay because of the pandemic. And so this is finally, we're going to be able to have her bring her information to University of Washington. Dr. Lebares is an assistant professor and acute care surgeon at UCSF. I met her in 2018 at the college, at the Forum, Power of the Forum, where she was presenting her data on a stress reduction resilience program that she had developed for surgical trainees and faculty at UCSF. It was a really powerful set of data that she presented, and I actually at that moment volunteered to bring it to UW if she ever decided to branch out. So this is our moment to help the department with the added support of Dr. Wood and Dr. Horvath to hear about what this program has to offer, what we might be able to do with it at UW, and to not only garner support, but to around resilience and wellness that has really been acknowledged at a national and international level from Dr. Lebares' group. So good morning, and Dr. Lebares, help us understand how to be well.
Okay. Thank you. Thanks a lot, Lori. And thanks for the opportunity to speak with you guys today about my work. This has been kind of a labor of love for the last many years, so it's really an honor. Let me try and screen share. Is that working? You guys seeing my, yep, okay. Okay, c'est moi, and I'll begin. So just a quick overview. I'm gonna very briefly just touch on burnout and distress, how they're related, kind of a definition of these things, their impact. I think we've all heard enough about that, so I'm not gonna linger on it too much. But then I'll focus for a while on why, in an attempt to impact burnout and distress, that I chose to target individuals, and then the data that supports this approach. And then I'd like to zoom out a little bit and just talk about some of the broader changes that we've seen at UCSF and elsewhere in terms of systems and culture that are stemming from this individual intervention. And then finally, just mention kind of the horizon, some goals for my own work, but then also gaps that are in this field that are ripe opportunities for others. So to begin with, at this point in time, we all have heard burnout described almost ad nauseum. We're all well aware that this is considered a prolonged response to chronic job-related stress, and that involves three subdomains: emotional exhaustion, depersonalization, and personal ineffectiveness. But as much as these definitions have been circulated and so much publication has happened around the prevalence of burnout, we continue to have very unclear understanding of the effect of gender, medical specialty, or age on burnout, and really equally poor understanding of the etiology of burnout, or really how to treat it. What we do know is that burnout's reach is negative and broad. It impacts physicians personally and professionally with substance abuse, mental illness, broken relationships, decreased quality of care, and an impact on hospital economics. More recently, Tate Shanafelt's group, who's been really pioneering in this work involving other types of physicians, they put out a paper that put a price tag on the annual cost of physician burnout, primarily due to attrition and then decreased productivity. $4.6 billion was the number they came up with. Particularly of interest to us, about 37% of that total cost was derived specifically from burnout in surgeons, and 82% of that $1.7 billion was derived from actual attrition. And particularly striking to me was that 64% of that attrition was due to surgeons under the age of 55 leaving the field. So clearly, this problem has a significant impact. And yet it remains really hard to address. Various interventions have been proposed to date. We've all heard about them. They span everything from increased cocktail hours to personal coaches and everything in between. And yet for almost all of these interventions, there's actually very little evidence to date, either supporting or refuting them. And underlying this lack of consensus is really this very highly charged debate about who is responsible for this problem. And certainly I imagine all of us have seen that argument in press. I think either someone's trying to ask a question or their phone is not muted. Hopefully it's not a question. Okay, so anyways, we've seen this argument in press, people describing this is not my fault, why should I as an individual take on the onus of solving this problem? Others saying, you know, well-being is a personal issue, why should I pay for your yoga class as the CEO of this health system? Thankfully, in spite of all that back and forth, there really is an emerging international consensus that the problem of burnout and its solution involves three reciprocal domains, and that includes things on the individual level, such as cultivating personal resilience or demoralization, on the institutional level, such as cultivating a culture of wellness or disregard, and then on the systems level, such as promoting systems that are efficient and help practice or that hinder that. And so currently, the understanding is, while we may focus predominantly on one part of this triad, all parts need to be included and addressed in any kind of sustainable solution. And so one thing we can agree on about burnout is that really it is a surrogate for distress. And it is therefore not surprising that data shows us, for instance, in this National Survey of General Surgery residents, that higher burnout, whether it be in the form of emotional exhaustion or depersonalization, really does increase the odds of an individual having clinically significant anxiety, depression, or suicidal ideation. But what was somewhat striking from the same data set is that when overwhelming stress is present, the odds of each of these risk factors occurring is actually 2 times higher. And this isn't entirely surprising because there are decades of research that show that overwhelming stress can be toxic in nature. When stress is overwhelming, it is a matter of demands outstripping our internal and external resources. And what it results in is sort of a toxic cascade that has demonstrated effects on our biology, our psychology, and our cognition. And yet we as surgeons in particular are aware that stress is not homogeneous, that in fact stress can also exist on the other side of this U-shaped curve, inverted U-shaped curve. And on the far side of this curve, stress is really a challenge. And so this represents instances like being pimped by an attending during rounds, and having the whatever is taught under that pressure sort of indelibly emblazed in our minds. It also really typifies many of the most memorable and informative experiences we have during our surgery residency. And so these are stressful experiences, but they are challenges. They are something that we feel we have the resources to overcome, and therefore they stimulate adaptation and mastery. And so one of the driving questions behind my work was, how can I help people shift the curve from stress perception in the realm of threat to stress perception in the realm of challenge? And so another finding that fell out of this national survey I mentioned a moment ago was that inherent mindfulness. So this is not mindfulness that is derived from specific training, but rather a tendency towards thinking and acting on the world in a certain way. When that is high, there are significant decreased odds of burnout overall, stress, anxiety, depression, and substance abuse. And so these findings, specifically in surgical trainees, as well as a growing body of work in multiple other high stress and high performance fields, such as in the Marines, among politicians, most famously in the UK Parliament, also among multiple professional athletes, both individuals, Kobe Bryant, LeBron James, but also sports teams. That includes the Warriors, just not shown here, and Olympic gold medalists, as well as urban school children. There is growing data that tailored mindfulness interventions that have a core set of skills, but which have been contextualized and streamlined for these specific populations, can have profound beneficial effects on stress and well-being, but also on physical performance, as well as test scores and cognitive function. And so what are these core skills that mindfulness training teaches? So really, consensus definition these days is that mindfulness is actually a cognitive process. It is not a day at the spa. It is not being thoughtful. It is actually a discrete cognitive process, and it involves learning to bring one's attention to experiences that are occurring in the present moment, and then learning to observe those experiences without reacting to them. And so, in fact, this is a way of training the mind to sustain focus and training the mind to maintain open awareness. So you can imagine it actually starts now to sound like a skill to maintain focus and open awareness all at the same time. And at its roots, mindfulness training is really training in a different way of perceiving things, including stress. And this skill, although how it is accomplished is not entirely understood, we know that it can be specifically developed through the practice of meditation. And the application, the benefit of meditation across all these various populations is actually not surprising when we recognize that stress perception is actually a very central mechanism within us that colors how we feel and think about and act in the world. So, for example, all stressors feel the same. That can be whether you're walking home alone late at night, whether you're taking the ab site, or whether you're encountering some surprise vascular anatomy in the OR. Your heart rate increases, your blood pressure goes up, your visual acuity is heightened, and maybe even your hands shake. But then something happens that allows you to discern from something that's a threat, like someone moving in the shadows late at night, walking alone, versus a challenge, like I know my anatomy and I have my skills and I can deal with this. And that really shifts what comes next. And what's important about this process I've described is recognizing that it's a process, which means that there are points along this process where we can intervene. And so based on these thoughts, I developed ESRT, Enhanced Stress Resilience Training, which takes core mindfulness training skills and contextualizes them for surgeons. And so the things that we're teaching surgeons are, again, this both focused and open awareness, emotional regulation, which really means being able to recognize thoughts, feelings, and sensations as they arise and just observe them. And then metacognition, which might be arguably the most important part of this as far as we're concerned, because it's recognizing that these skills can be cultivated and then called on when we need them, even though almost all of us are already aware of what it feels like to be resilient, sort of by accident. If we didn't, we wouldn't be here and we would never have survived a difficult training or a difficult OR case. But the difference here is that we're talking about how to train this so it can be used and called on when we need it. So with ESRT in hand, since 2016, we've conducted 2 randomized controlled trials. In all of these, we've done multi-domain assessment, looking at scores at baseline, which is before any experience in intern training has begun, and then after the administration of ESRT, and then at some point of follow-up, either 6 or 12 months along. And in all of these instances, we've pitted ESRT against an active control. So this has been a group that's had the same amount of protected time, a break from their clinical services, the opportunity to develop a peer group where they share issues, and then the opportunity to develop a relationship with a faculty. And so our control was comprised of those elements, just not mindfulness. And so stemming from these randomized controlled trials, we've now been able to demonstrate feasibility of such a program within an academic surgical residency. We've seen that resident participants are able to practice consistently and able to find a consistent amount of practice time per day that persists throughout the duration of the course, and in many instances actually persists over years, which I'll talk about later. We've also been able to show that in the control group, the intervention group represented here by the orange line, mindfulness scores increase in a statistically significant fashion, as do global executive function scores. You may notice here that the effect on executive function seems to grow over time, and this is actually not surprising since this is not a trait, or not a state, but rather represents a trait or an attribute that develops over a period of time. And this same trajectory has been described in work by Amishi Jha involving Marines. We've also seen that in the intervention group, again represented here by orange, statistically significant lower levels of emotional exhaustion and depersonalization. And this includes over time. We've also looked at physiologic effects, specifically the effect of ESRT on gene regulation. Precisely, we're talking about transcription factor activity for two different signaling pathways. One is the pro-inflammatory pathway, and the other is beta-adrenergic signaling that drives the sympathetic nervous system. And what we saw in controls was an elevation of these signaling pathway transcription factors, 1.5-fold higher than baseline after they had after ESRT or the control had been administered. So this is after they'd had roughly 2 to 3 months of exposure to residency training. And this amount of amplification of these transcription factors is similar to the profile that we have seen in populations that are experiencing sleep deprivation, chronic loneliness, malnutrition, or distress. And yet, thankfully, in the ESRT arm, what we saw was that this enhanced activation of these signaling pathways was reduced by a little more than 50%. And so not restored to normal, not restored to baseline, but reduced by 50% from this rather dramatic increase. We also looked at activation of neural substrates through the use of fMRI. In particular, we looked at how those who had received ESRT were able to perform emotional regulation when we gave them this sort of well-defined emotional regulation task. They were told to look at multiple pictures, some of which were very innocuous, like a lamp, and others which were very provocative, like a starving baby with a vulture waiting in the wings. And they were told to decrease their emotional response. And in this setting, what we saw was unique and significant activation of two different parts of the brain. These mapped to the right dorsolateral prefrontal cortex, which is recognized as the executive control hub of emotional regulation and aspects of complex problem solving. And then also the precuneus, which is on the lesser known part of the brain, but which is attributed with self-awareness. And that includes both internal self-awareness, like interoception, thoughts, feelings, emotions, but also external self-awareness, like proprioception. Where do I exist in space, and where do I exist in relationship to other things? And it's believed that this part of the brain is involved in self-agency. And so just to reiterate this, what we saw was unique and statistically significant activation in two neural substrates, the right dorsolateral prefrontal cortex and the precuneus only in those who had received the ESRT intervention and only after they had received it when they were challenged with this emotional regulation task. So all of these things taken together and a mountain of subjective feedback have led us to believe that we are, that our residents are learning to shift the curve. And so an example of their subjective feedback that supports this, when I get stressed, I tend to spiral in my mind. I start thinking I'm doing it all wrong. I'm no good. I shouldn't be here. But ESRT has helped me take a second to see this response and to note it. So now I can float back to the top and say, oh, this is uncomfortable. This is stressful, but that's okay. Residency is just hard for everyone. And so again, that experience of profound stress and a acknowledged capability to shift back to a more balanced place. A couple more quotes just about how this was brought to bear on day-to-day life as a resident or just a human being. Once I learned being in the moment, I became aware of my body in the OR. I would hold my breath, clench my stomach, but now I breathe. It brings everything back into focus. Also, somehow I've gained some space between me and my reactions. Those late night consults, hammer pages, I get so angry. But now I recognize this reaction. I can see things a bit differently. This isn't personal, they're just worried. Being angry won't make them stop. Getting that angry just hurts me twice. And so as a result of all this, these positive outcomes, we have now been able to formalize ESRT into a curriculum bundle. The current form of ESRT is comprised of 5 weekly 1-hour classes. There's a graded daily home practice assignment, and then booster sessions. And we've continued to work very hard to develop a training manual so this can be disseminated. We've included an app-based platform to help support people's daily practice, and then video components of past participants speaking to how they use these skills in real life in order to bring these concepts home. And so here's an example of that.
So I use the mindfulness for a couple of different techniques throughout the day. I think one thing that's really helpful for me is mindful scrubbing in, meaning before we scrub into surgery, I like to take those 2 to 3 minutes to, instead of thinking about all the things that are waiting for me and the surgery that's coming in and everything else going on in life, I just practice mindfulness and completely focus myself so that when I go into the operating room, I'm completely calm, my heart rate's down, and I feel like that way I'm better centered going into the operating room. I think it's also very useful to transition between work and home. So before, I used to go home and kind of bring all the energy and the negativity and stress from the day home with me. Whereas if I practice mindfulness as I'm walking or driving home, I feel like that way I'm able to acknowledge the day, kind of let it go, and then go home without bringing it all home with me.
And so as this intervention has grown from a bottom-up approach and been disseminated across more and more years of residents, to date, we've now trained 45 of the current general surgery residents in our department with ESRT. It has begun to spread to surgical faculty. So that's an example of this here. Surgeons at the end of a long day, taking ESRT in the campus library. And then also this skill set itself has begun to garner just national acknowledgement of its value. And so this was a piece in JAMA Network. But we've also begun to see how residents are not only receiving a positive impact during the specific time period of the training itself, but rather they've incorporated these skills longitudinally into their work and lives. And we think that this is part of what has driven this broader culture change that we've seen. So as an example, this is a resident who took part in ESRT in 2016 as part of Wave 1. And this is 3 years later, asking what he got out of his training, and he ends up describing actually how he continues to still use these techniques.
When I would leave the morning sessions and go back to work, I felt more energized. I felt more peaceful. I felt like I was able to deal with anything that came throughout my day. And it's all because of what we did during the course itself. Learning how to interact with others, whether it's nurses, your co-residents, your attendings, in a productive manner, realizing that people might want to fight you in a hospital and you don't have to engage in that. I think those are some of the lessons that I've taken and kept from my.
And so this has also allowed us to expand on this idea of the value and importance of this skill set, to where in 2020, not only is ESRT a mandatory part of our educational curriculum for PGY1s, but we've also begun to talk about how could we build on this basic skills training of PGY1s and take this into further levels of residency training in ways that are even more tailored and specific to what higher levels of residents experience. And so we're currently working on bringing already established mental skills training, such as Dimitri Stefanidis' mental skills for performance enhancement, into our surgical skills lab to begin talking to residents about how they would build on their ESRT skill set in order to help them in the midst of operative training, using what is currently being called sort of embodied learning. So understanding how your emotional state is driving your physical performance. And then also for lab residents, when this tends to be a time of sort of restoration and a little extra free time, we're looking at engaging them in more quality improvement. So this is beginning to use sort of the mindfulness perspective, open-mindedness, and a sense of possibility to look at many of those things around our workplace that drive our sense of burnout and unhappiness. The Institute for Healthcare Improvement has come up with this Joy in Work program, which is actually this phenomenal online set of modules that helps train people in how to both encourage their colleagues to identify what they call these rocks in their shoes and pass those on to administration who've made a commitment to change these things, which has this profound effect even while big issues, boulders, are still being pushed up the mountain. And then finally, in senior residents, PGY 4s and 5s, this element of the longitudinal curriculum was actually really inspired by them, asked for by them, which involves having senior faculty who've undergone ESRT talk about specifically how they apply these techniques when it comes to complications, leadership training or issues, litigation, or even intraoperative doubt. And then lastly, making sure that we have robust assessments that can assay the successfulness of all these different components and help us really focus our goal towards developing well-being, not just identifying pathology. And so we believe that this internal curriculum is going to help us build surgeons who look just as good and perform just as well on the outside as any other surgeon, but which have this internal skill set that can be applied not only during residency training, but really as a centrally derived skill set, essentially focusing on this central mechanism. It's something that they can hopefully apply across the trajectory of their career. Two examples of how this internal skill set has sort of come to my attention in the real world involve two different residents. One was in a very difficult paraesophageal hernia repair with me. There was an emergency gastric volvulus, and of course, incredibly old and frail lady, as always is the case. And this PGY3 who was with me had very little experience running the laparoscope, and I was unfortunately expressing that mainly by stamping my foot and sort of, breathing smoke. And this young woman who had had ESRT training turns to the medical student and says, "This is where I practice my mindful breathing. Later, I'll teach this to you. So the next time we're in this situation, it won't be like this for us." So in other words, applying these skills to deal with an attending who might be upset or overly demanding. And then the other example was more recent, that I had been on ACS service. It was incredibly busy. We had, myself, my PGY3 and our intern had ended up doing this case, and it was very difficult and long. And in a subsequent case, I was discussing it, and part of my decision making, I said, oh, like an idiot, I didn't just decide to do it the easy way. I stuck with the hard way, and that's why it took longer. And both the resident PGY and the intern who have taken this training looked up at me and said, don't you think an idiot is kind of a harsh word? And I thought, my God, who are these people? Because when I was raised in surgery, idiot was basically a replacement for your first name. So things are changing. And one last quote that exemplifies this, going in, I didn't have high hopes that this mental training could work. But now I'm a strong believer. I don't know if mental training actually reduced my stress or not, but those 8 weeks changed my perspective on things. I'm able to incorporate it throughout my day at the hospital in so many settings, allowing me to deal with stressful situations and encounters. It's nice to come home and meditate after a long day. It puts my mind at ease. I think there are so many subjective gains from this experience that a p-value shouldn't be what decides if we get to benefit from it. And then finally, recognizing that the real goal here is well-being and is the restoration of joy in this field that we've all worked so hard to join. And here's another video vignette that describes this sort of in the subtext of what you hear. And this is Dr. Harris, who's a professor at UCSF and current chief of the Division of General Surgery.
So my favorite exercises are when I'm walking into the hospital at 5 a.m. to really pay attention to the feeling of the pavement under my feet. And I know it sounds kind of funny, but I find that is a very interesting way to just once again recenter and reclaim the kind of attention to the moment. Secondly, I like practicing meditation when I am waiting for things in the hospital, whether I'm waiting in pathology for a pathology result or on the elevator, waiting for the elevator. I find these short little moments, times that it's just nice to, once again, refocus.
So again, probably one of the biggest cultural changes that's happened for us is a shift from simply identifying where pathology is and or how prevalent it is to really looking at what does it mean to cultivate well-being, how do we do that, and how do we monitor our progress in doing that. This is just the CDC definition of well-being. The point of it is simply to say that it's far more than just an absence of disease, that it really talks about sort of the optimal functioning on multiple levels of a human being. And so in pursuit of this, in 2019, we started looking at this measure called flourishing. And it's quite different from simply evaluating the absence of depression or overwhelming stress. Because what flourishing encompasses is well-being in terms of psychological well-being, social well-being, and emotional well-being. And so the beauty of this measure is that it really looks at how an individual is doing as a whole person, sort of regardless of whether or not your flourishing is dependent on low stress or low burnout or other aspects of your personal environment. Instead, it just looks to see, are there things inside and outside of you that are diminishing your ability to flourish? And so it allows us to kind of account for that individual factor. And what we saw from some of that work was that flourishing was positively correlated in a significant fashion with social support at work. And this was actually very interesting because if you had asked me 4 years ago if social events were important, I would have said probably not, or to a minimal extent. But in fact, we know from occupational science, and in particular the job strain theory, that high demand jobs can maintain worker satisfaction as long as control increases sort of in tandem with increasing demands. And that's exemplified here by this curve. But what we also know from more recent theory and empirical work in occupational job strain theory is that when social support is present, this whole curve moves up. And in particular, this is true for women. And so, once again, not expected, but this is the benefit of looking for evidence, is that it suggests that social support, although we're not sure in what kind, does that mean mentorship? Does that mean cocktail parties? This is a gap that remains to be filled. But nevertheless, it begins to allow us to begin focusing where we are aiming rather than just using this shotgun approach to fixing burnout. And then, of course, happily for me, we also found in that same data set that flourishing was, to a slightly lesser extent, positively correlated with high mindfulness. And further, we started to look a little bit more at the differences in risk factor and resilience factor prevalence in our male versus female residents in order to understand, are there differences in how males and females are experiencing surgical training, and are there differences in how we need to address their well-being. And certainly this figure here is a little messy, but the point of it is to simply say that odds of higher depersonalization among female residents and the odds of higher mindfulness among male residents were two findings that were statistically significant. And then there were findings of higher emotional exhaustion for females, higher alcohol abuse for females, and a much lower prevalence of flourishing in females that had confidence intervals that suggested that if perhaps we looked at this on a larger level, these might be statistically significant findings as well. But overall, we've taken this to show us that we do need to pay attention to gender as we're moving forward in this work. And so finally, as a whole, this has led us to be able to begin creating a conceptual framework for the external factors, those things that on a systems and programmatic level we can address, such as the psychological demands of work, or perhaps increasing a sense of control or autonomy, providing mindfulness training, and addressing social support, understanding exactly what it means to improve that for a man, for a woman, or for residents as a whole. And then recognizing that these things appear to have this relationship to internal factors, although we don't know the directionality of these relationships at this time. But we do know that they have an impact on whether flourishing is present or not. And so while this conceptual framework may very well look ridiculous in the future when we know more, at least it begins to help us, again, focus critical resources and precious time towards things that have a higher odds of yielding results. And so this begs kind of the central question that I think every program needs to ask itself when approaching on this idea of what to do about burnout and well-being. And this is well-being a nose job or a cleft palate? And by that I mean, is well-being, like a nose job, something that's elective? So it certainly makes us feel better, but it is not really necessary. It is a matter of personal choice, and thereby addressing it should be a matter of personal priority. Or is it like a cleft palate repair, something that is fundamentally necessary, that without we don't function properly, we are effectively handicapped, and thereby it is a fundamental need, something that as a whole, as a specialty or as a society, we need to give higher value. And so finally, no talk would be complete without a mention of the impact of COVID. I love this picture. It just makes a little bit of light out of a dark time. And another little bit of light that has come out of this dark time has to do with a survey of anxiety that our department did about 6 weeks after the emergency response had been triggered at UCSF in regard to the COVID-19 pandemic. And this survey was very simple, just looked at anxiety and how it related to shifts in high COVID exposure settings like the ICU or county hospital, how anxiety in this setting related to gender or I don't remember other factors. But what we saw was that there was this very surprising distribution of anxiety where the highest scores were actually being found in more senior residents. And what was surprising about this was that there are other studies that have very clearly shown that in most groups, anxiety tends to decrease as training level progresses. So the anxiety of PGY1s is statistically significantly higher than that of senior residents. And so it was curious to us that we were seeing this effect, and then it occurred to someone, sadly not me, that in fact, we had exposed 45 current PGY 1s through 3s to ESRT when they were interns. And so that meant that about 55% of our current PGY 1s through 3s had experienced ESRT sometime in the past. And yet 0% of our PGY 4s and 5s had had ESRT because when they were interns, this wasn't available. And so we reanalyzed this data, looking to see what the effect of having been exposed to ESRT might be on anxiety scores. And what we saw was that regardless of PGY level, in those people who had not been exposed to ESRT, high anxiety was just over 20%, while in those who had been exposed to ESRT, high anxiety was just over 3%. And this was a statistically significant finding. Anyone who can see holes in this, I'm there with you, because this wasn't a study. This was an incidental finding, but it does suggest to us that there may be a lasting effect or ability that comes from this kind of fundamental training that allows people to deal with dramatic changes in their environment. And then finally, COVID also allowed us to develop, or prompted us to develop, a remote version of ESRT. This is something that's live streamed from instructors who are local to UCSF. And in April of this year, we rolled this out across 4 time zones, including academic, community, and military surgical trainees and practicing surgeons, and found that it actually works very well. We haven't had time to collect objective data on this, but the subjective feedback has been very positive. So this just gives us another tool to help with the dissemination of this training to those that are interested. So in closing, on the horizon for us personally, me personally, my group, is working to disseminate ESRT to those people who want it, particularly through remote use during 2020 and probably 2021, since COVID doesn't seem to be going anywhere. But also assisting organizations in the implementation of a program like this. Because in fact, we all know that getting from bench to bedside can be a tremendously long and difficult journey. So just having an evidence-based practice like ESRT is not the same thing as having an answer to your well-being issues. Really, it involves kind of a complex and multi-level effort to bring these things into the surgical culture and curriculum. And so currently we're working on that with institutions in Wales, the Royal Canadian College of Physicians and Surgeons, and then several programs in the Middle East. And then also focusing on how ESRT may need to be adapted in order to fit into other unique contexts. So this might be the context of University of Washington, or specifically we're working with the American Zoological Veterinarians Association, predominantly right now at the Oakland Zoo, to explore how ESRT might be adapted to help veterinarians. And then of course, gaps in this work are really the need for a multi-site trial. Much of the data that I've shown, the fact that there were statistical findings, statistically significant findings, was quite a shock, because these are small populations, just limited strictly by their by the inclusion of only a single institution. And so more institutions, I think, will make this data more robust. And then of course, the critical need for us to further explore individual needs as they pertain to race, gender, orientation perhaps, and of course the local environment, recognizing that UCSF and UW might both have surgical training programs, but we're not necessarily the same. So I will leave you with that, and thank you very much for this opportunity and for your attention. And I'd like to specifically thank Dr. Langdale, who years ago when she approached me after that talk really was sort of like a beacon of hope for me, that this wasn't all a waste of my time. So thanks very much.
Dr. Lebares, thank you for a fantastic presentation this morning. Thankfully we have time, because I'm sure there will be plenty of questions. I think we'll start by leaving it open if anyone would like to actually do a question directly via video Zoom. And then past that, I'll go ahead and moderate chat if you want to enter your questions there.
First, thanks so much, Carter. Hi, this is Lori. I thank you very much, Carter. That's so exciting. And I guess I really want to emphasize to the group how important these data are, because there are relatively few studies that have taken such a scientific approach of really analyzing the impact of an intervention like this. That most people would look at this and say, oh, this is kind of touchy-feely. It's not. This is actual science. And what hopefully Dr. Main and I have been urging bringing this program to UW is not only to support our residents, but to support our faculty. And I really hope that as we launch this over the next several months, that there will be folks who step forward and say, you know, I'd really like to give this a try. We're in a stressful time, and this really has an opportunity to improve not only our personal wellness, but our overall culture and how we work together. So thanks again, Carter. I really appreciate it.
Karen?
Dr. Lebares, this is Doug Wood. I'm going to follow Dr. Langdale's thanks and tell you how appreciative we are that after postponing this as a in-person grand rounds, that we were able to get you with us virtually, which we've now all learned, at least for a while, is replacing our get-togethers. And I also want to express my appreciation to Drs. Langdale and Main, who suggested bringing you here for, I think, this really important presentation to us, and also for leading this effort for us to cascade the work that you're doing at UCSF, hopefully here at the University of Washington. As also, I'll just mention, great to see the vignette from Hobart Harris, my college and medical school classmate. So it was nice to see Hobart also acknowledged in your talk. So this is really exciting, and Dr. Langdale is right. This is hard science, and it's science that actually provides some opportunity for benefit to us in how we work and how we work and flourish. And that's something that we really care about in our program at UW. So it's great to have some concrete ideas of how we can be better. So I don't have a question. I just wanted to acknowledge and thank you, and thank Dr. Langdale and Main for making this possible.
Go ahead, Karen.
Thank you. Dr. Lebares, thank you so much for a wonderful presentation. I'm so excited about our partnership with you at UW. I just want to kind of acknowledge that, ditto what Dr. Wood said. I have a question about the value of social support, which I really think is intriguing. And I think I see social support as being the same as community. And I think we can all acknowledge that with the intensity of our surgical lives, that our department is very much our community in surgery. It's kind of different than people that don't have such intense lives. They have, the PTA and, other sorts of things, right? But our department is our community. And I was wondering if you can share some examples, just kind of real live practical examples of some of the community kind of building or maintaining things that you do at UCF in your department.
Yeah, so this is something that we're exploring too. So these institutional and systems-based interventions are still really under exploration. But one of the things we think sort of a dual effect of the ESRT training is that it does create this shared experience. And so in a sense, it actually itself promotes community, not just an individual asset. So I've on multiple occasions seen people surprised in the OR that the person across the table from them is practicing a breathing technique when things go to hell, or laughing when they realize that someone else was part of one of the exercises in class where you feel a little bit funny, but it's actually quite good for you. So there certainly is that. But then I also think that probably the way to approach this going forward is to really try and drill down on what people perceive as being social support, because my sense is it's probably going to be different for different people. And trying to just do one large event like a party or I don't know, people are coming up with all kinds of interesting virtual things now, may help some folks, but may not really target the folks that you're aiming for. So my first recommendation would be to just ask, to purposefully send out a survey. Like, what would it look like for you to have social support activities or social support itself within our department? People might say, once a month, I'd love a meal delivered to my house that I don't have to cook myself. Who knows?
All right, I'm going to go ahead and I apologize, everyone. My video is not working, but I'm going to go ahead and start moderating some of the fantastic questions we're getting. So the first one from Dr. Sarah Kim. Thank you for your important talk. Do you have any formal measures or anecdotal input from nurses or other specialties regarding the quality of their interactions with your residents as a result of ESRT?
You know, that's a fantastic question. And that kind of third person feedback is something that we've thought about quite a bit. One year, we did in fact try to gather that feedback from patients. And we used two different measures that in the outpatient setting have been shown to really be excellent tools for getting patient-derived feedback on physician performance. In regard to both kind of decision-making, empowerment, and empathy. And what we discovered was that, at least in the inpatient surgery setting, most patients don't even know who their intern is. So unfortunately, and they also confuse all of us. And so we found that that just wasn't logistically feasible. But I think what you're describing is really the next step, is to begin asking other subspecialties, other allied healthcare providers, what their impression is. How exactly to do that and be able to filter out sort of personal prejudice is a question that we still don't know how to address. But if you have ideas or you're interested in that, I'd love to collaborate with you on pursuing that at UW.
So our next question is from Dr. Sam Arbabi. Says, I was surprised by the difference in men and women, especially higher alcohol abuse in women. Do you think this is a self-report issue, male doctors perhaps not recognizing stress or signs of alcoholism?
You know, I don't think it's a reporting issue, because we've seen, even as far back as Tate Shanafelt's initial 2008 American College of Surgeons survey that captured, I think, over 50% of all practicing surgical fellows of the college. This same finding of greater alcohol abuse among female surgeons was present, and it has been reiterated in multiple surveys of residents and practicing surgeons across surgical subspecialties. And it's surprising, sort of. It's surprising because in the general population, men persistently and consistently score higher prevalence of alcohol abuse than women. But in surgery, maybe this actually speaks not to a reporting error, but rather to a different experience, that perhaps women are using alcohol in some fashion as a coping mechanism, a coping skill.
So our next question is from Dr. Kevin Sullivan, and there's a bit of a follow-on actually by David Hannell. So it says, I was wondering about the generalizability of ESRT beyond surgical training and faculty. Is there any data in non-surgical residents, or are there any plans to expand its use to other specialties? And sort of a follow-on comment to that by David Hannell is, you know, why stop with surgeons? Perhaps it pushes stress and concentrates it in the rest of the system.
Yep, those are great points. And you know, I started with surgeons with the hope that sort of the social cachet that we have within medicine and outside of medicine might help convince others to try this. And indeed, that's been the case. After the first year or two's worth of data had come to light, we began getting inquiries and interest from multiple different institutions around the Bay Area and different departments within UCSF. So in 2020, the Department of OBGYN will continue to have ESRT be a mandatory educational training for their incoming interns. This is the third year in a row that they've done that. The Department of Emergency Medicine allows their interns to opt into training if they want. This year would be the fourth year that they would do that. We've also rolled this out to internal medicine at some of the private hospitals in the area and allied healthcare providers through the San Francisco VA. Now, those populations, those specific populations, we haven't done as deep of a dive in terms of all of the objective measures that we've looked at in our own, mostly just because of resources. But the subjective feedback and some of the self-report measures are consistent. They show that this works for them too.
So just for the sake of time, I'm going to kind of compile the last few questions. Ultimately, there was a request from Dr. Langdale and sort of a comment from Dr. Browning. So Dr. Browning, Ann Browning made the comment that as part of moving the dial on well-being across UW, we are actually looking to help translate ESRT across disciplines. With that in mind, Dr. Pellegrini asked if there was any downside or unintended consequences with ESRT, and just maybe to finish, could you kind of outline for us what kind of departmental commitments are required to make a program like this happen?
Yeah, those are great questions too. Thank you. The question of downsides dovetails perfectly with the necessary departmental commitment. And what we've really seen, and this is elaborated on much more in an implementation paper published earlier this year in the American Journal of Surgery, if you care to look at it. But what we have seen is that it is really conflict that makes the impact of, that diminishes the impact of ESRT training for the interns. So that can either be conflict due to having to choose between another educational activity that's ongoing during the same time as this training, or having to choose between staying with their team and, for instance, rounding or come to this training, or having their workload pushed onto someone else while they attend the training, whether that's a nurse practitioner or another resident. And part of what makes that sense of displeasing the team so particularly onerous is if the team itself doesn't recognize from top-down influence that this is an important endeavor and that their turn will come too. And so breaking that down a little more clearly, what I mean to say is the investment that's needed is really a decision to move forward, and then the creation of protected time that's already has scaffolding around it to prevent upheaval in who has to take on that intern's duties. So for UCSF, we've decided to implement this during Wednesday educational days, because already everyone who remains at the hospital knows that they're going to have to take care of work for those people who are attending educational sessions between these hours. And we've simply consolidated some other sessions to clear the necessary 5 hours in a row, 5 hours once a week, or excuse me, 1 hour once a week for 5 weeks, in order to make this possible. And all of that really requires that the local champions sit down with the program office and really look at schedules, clarify what rotations people will be on, how much work will be shifted, how feasible is that? Is the intern the only resident on the service? These kinds of questions that are certainly resolvable, but shouldn't be missed. And then also just a strong statement from the top. An example of how powerful that is Mount Sinai in New York. Just prior to the onset of COVID, their chief of general surgery contacted me to talk about ESRT and said that their chair had reached out to all division chiefs and said, I've read the literature, I've seen the data, I've tried this myself, and I'm going to require that you take mindfulness-based cognitive training. And so he did. And I think it was 8 division chiefs attended. And as a requirement, the time was, compensated or cleared for them. And they got a tremendous amount out of it. And this really inspired this top-down support, which ironically was well in place and already galvanized a few weeks before COVID hit. And so what Celia Divino, the chief there, described to me was this immediate willingness to implement periodic mindfulness practices on a daily basis to support their whole department. And she's just writing up sort of the qualitative results of that endeavor right now. So those are really the things that are needed, and that's the impact that you can have if you set this up kind of the right way from the beginning.
Thank you again so much, Dr. Lebares. I think we're about out of time this morning, but stay tuned. We're not done after this morning's presentation, and we look forward to the implementation of this program here at UW in the future.
Thanks a lot.